diagram you guys have seen, but it's fairly terrifying because it kind of lays out your whole life all in one diagram, which I think is a little bit unnecessary. But the general thrust, as you guys probably know, is that you do an F1 and F2 year, and then after your F2 year, you make a choice. You're kind of a free agent, and you make a choice to do other things. So you can go into GP training or other specialty training like I've done. You can take time out. There's a lot of possibilities. And I don't want people to be terrified and start thinking about the next 10 years or the next 8 years or thinking about that kind of stuff. I just want to talk really about what a foundation doctor does, and why I think it's a really good option. Remembering kind of how I was when I was in your shoes in Italy, why I think it's a really good option for you guys to start to feel like to really feel like a doctor and to learn your clinical skills and that kind of stuff. But I do think I like this picture because someone summarized it all really well, and it gives you a bit of a schematic. But similarly, you know, I think there's a risk of being terrified by the whole thing when you see it all laid out like that.
I
Guys,
mean, at least it's a good start to sort of see the general steps of things, and once you're, you know, starting your junior doctor years and beyond even, I mean, you will slowly sort of learn that there's so many ways to get to one place. So
yeah,
I feel like it's always, at least it helpful for me. There's probably 40 people in this school, so you know we all see things a little bit differently. But for myself, I would say that is all. I always like to see something from afar quickly, just to sort of see how things can be, and then obviously have that structure, and then you know later on you can change and take your own route, let's say, to get to where you want to be.
I mean, what are the main things that as an F1 you felt you achieved that you will? I mean, there was a lot of things I was waiting to do as a final year medical student that I felt like I was finally able to do as an F1, which I think is a big goal in itself. I mean, many of you might have dreams of doing very big things, but I think it's about learning certain basic things. What do you
Yeah.
think, Nad?
I mean, I just for me, I always felt like I just wanted to be comfortable feeling like saying I'm a doctor, you know, and obviously I don't like saying it generally unless I'm in hospital, but you know, if someone needed something in a hospital, like as a medical student, I wanted to be comfortable saying, oh yeah, I can give you a hand. And I think foundation year does help you do that.
Yeah, I
Definitely
think
does
it's,
help you do that.
and I think also in Italy, it's about you've studied for so many years on books and things, haven't you? And you wait so long to kind of finally be able to do actual clinical practice, I would say. So I was just gonna, maybe some of you guys know how the hospital hierarchy in the UK works, but your kind of typical people, doctors, are your F1, F2, people a little bit more senior than that, which we call SHO, so senior house officer, or your kind of junior trainees. So that's probably where I am now. Then you have your registrars and you have your consultants. So the way I'd summarize it is your F1, F2 is very much like an errand boy or like the vegetable peeler in the restaurant. Like they don't have a lot of skills on themselves because at the end of the day, you can only do what you're capable of doing. So the F1 is job is really to organize a lot of stuff, do a lot of the bureaucracy. And the other thing is they get bleeped constantly, and we'll talk about what that means as well. They get bleeped constantly as well. So In a way, a lot of the job is there's a lot of bureaucracy, you know. So if say someone needs a chest X-ray, it's the F1 that needs to like organize that, you know, write out a form, fill out a form, go. So there's quite a lot of it that's not really being a doctor. It's a lot of getting stuff done, but at the end of the day, you are like the lowest rung of the team. And you know, so you've got to kind of, you're not going to be on your own doing loads of stuff. The F1 is an important person because the whole team actually functions because of the most junior doctors. It's like any kind of big team. The workhorses are the most junior people. So F1s, F2s are really important, but your kind of job is not going to be like deciding treatments or diagnosing people or anything like that. So that's your kind of F1, F2 errand boy, vegetable peeler person. Then you have your SHOs, junior trainees. So someone like me who's got a couple of years experience, and I can definitely advise, like, you know, the F1s and F2s who are around me, what they want, what they need to be doing. And I'm there learning. But ahead of me is your registrars. So your registrars are people, so I'll be a registrar in kind of 3 years into my training. So the registrar is someone who has done some exams in their specialty, and they're an important decision maker and a kind of team leader for everyone more junior than them. So they're really important in the hospital. They take a huge amount of responsibility out of hours, so evenings and weekends and nights. The registrar is the most senior doctor. So I've just done my first exam in my pediatric specialty. So basically, in your first years doing your specialty, you'll have to do some fairly tough exams, which I think is really important and really useful, because they really make you, you know, you've chosen to do that specialty. So obviously you're going to do some exams to prepare yourself and really know what you're talking about. So I've just done my first PEDS exam. But the registrars have kind of done all of that. I think when people talk about specialty being 3-4 years in France and Spain, they're kind of talking about maybe that level of doctor, the kind of registrar who's had 3-4 years. So when I'm a registrar in I'm an ST1 now, but kind of ST4. Then in the evening, you know, if a baby gets sick or something, I'm going to be the most senior person there, making all the decisions. And the consultant, who's the in charge person, is kind of going to be at home. And if I need more help, I'll have to basically call them at home and make them come in the middle of the night. So the consultant is not usually around very much. They have overall responsibility of the department, and like the name suggests, they're there to consult and provide leadership and management as well. So they kind of run the department, not just from a point of view looking after the patients, but like the finances, the leadership, you know, the people working there, all the other things that go into running a department is a consultant's responsibility. So we'll talk about what all those different people kind of do during the day. I don't know if all of that made sense. If anyone has questions, please just put it in the chat box.
Yeah.
Kind of if we're not making sense, because I think it's very difficult. It's very difficult for us to like unknow what we know sometimes and remember not things when things weren't so obvious. So I hope I've kind of given you an idea of what an F1, an F2, an SHO, a registrar, and a consultant, and how the hierarchy works. Did you want to add anything, Mahads, in terms of?
No, I think we can pause quickly for like anyone to ask a question. There's quite a lot of people in here, so maybe it might be best to just write in the chat.
Yeah, I think write it in the chat, and we can talk through
exactly.
this. So that's kind of how you fit into people further above you. So an important person, but still bottom of the rung, really. So what does an F1 do during the day? So rotas are really different, and there are kind of laws about how many hours you're supposed to work and things like that. So typically we get short days and we get long days. and then you kind of will get days off before and after if you're doing long days. So when I was an F1, you might have long days, either like a Friday, Saturday, Sunday stretch of like long days, or a Monday, Tuesday, Wednesday, Thursday stretch of long days, and then you might have weekends, you might have nights. So depending on, it's very variable, but I mean, most of us do work fairly hard, I would say. Um, but yeah, in Europe, unlike in America, we have better laws that kind of limit how many hours we should be working. So we're going to run through what you're going to be doing, what you'd be doing on a short day. And the reason is because, frankly, when I became an F1, I didn't have a clear idea of what an F1 really did. And you can't really be a good member of your team unless you do know what an F1 does. So like I was doing on-calls without really understanding what an on-call entails. So although I think I was very on it applying and knowing where I wanted to work and all that kind of stuff and knowing I want to be a pediatrician, I kind of didn't have a proper idea of what my role would involve until I really started F1. And so that makes it a lot more difficult. So short day is kind of typically 8 a.m. to 5 p.m. roughly. So first job of the day is to receive handover. So this is when you get your new patients for the day from the night team, basically. So you'll be given a certain number of new patients that you're going to take care of. So the F1 is typically responsible for the team list. Your team will have a list. It's usually just a Word document, nothing very sophisticated, but we'll have your list of patients and, you know, some things about them, like obviously like their date of birth, what they've come in with, what kind of treatment they're being given, and what jobs need to be done for each patient. So that list is very, very important. It's kind of a legal thing. You can't lose it. You know, if you lost it somewhere and someone else found it, that would be a real disaster. So the F1's often kind of in charge of updating the list. You can already see that what F1 does is really different to what you learn in med school, because these are not the things you learn in med school. So being in charge of the list. When you receive handover, they'll tell you, okay, you've got these 3 new patients, Mr. Henderson, Mr. Jackson, and Mrs. whatever, Mrs. Black. And these are the issues they've got. This is what's happened to them so far. This is why they've come to hospital. So you're going to add them to your list. And then the main activity of the morning is ward round, which I'm sure you guys have seen a Giro probably in the hospital over in Italy. But it's usually led by the consultant. And the job of the kind of F1s and the juniors is to present the patients. The consultant comes in, he's busy, he or she hasn't got a lot of time, and you basically have to take the consultant round to each patient. So you need to know your patients. The F1 needs to know every one of their patients and what's going on with each of them, basically. So you take your consultant from one patient to the other. So you need to know where the patient is, who they are, what's going on with them, what they've come in with, etc. So when you get to the next patient, you have to present the patient to the consultant. So you can see there's a picture there of the patient, the consultant, and a bunch of juniors. So the juniors need to say, this is Mr. Jackson, he's coming with this, he came in overnight, he has these issues, and this is what's happened so far. And then the consultant will listen to all of that, might ask you a couple of questions. So you need to know stuff about your patient so that when the consultant asks you, what was their calcium? Or how long have they had that issue? Or why are they on statins? Or whatever, you know, it's quite daunting at first, but you just got to get used to questions being thrown at you. So present your patient, the consultant's gonna examine the patient, talk to the patient and then give you a plan. And then you have to document. So another thing I don't think we really learn in med school is how important documentation is. So everything that happens in a hospital has to be written down. It's a legal thing. So if it's not written down, it didn't happen. So the F1's job is, while the consultant is seeing the patient, to document the ward round. So ward round, doctor, whatever the consultant's name is, and then, you know, what the patient came in with, what we've done and what their plan is. So your consultant's going to say, I want a chest x-ray, I want them to put in these antibiotics, I want this done, I want a COVID swab, and I want you to talk to the patient's wife, and then they're going to move on to the next patient. So you'll have all of like 3 minutes to write down what the consultant told you, and then that's it. So that's kind of your morning will go like that, just seeing your like 10 or 12 patients on your ward round. The consultant will disappear and you won't see him again. And then it's kind of like you, your registrar, maybe your F2, whatever. And then in the afternoon, you're going to spend doing all the jobs from the ward round. So you've got your list of patients, and on your list, you're going to write down what needs to be done for each patient. So patient number 1 needs this doing, patient number 2 needs a CT scan, patient number 3 needs that thing doing. And then your whole job in the afternoon is essentially getting all those jobs done. So as I said, you're kind of the workhorse. You're the runaround boy, the errand boy. You're the person going to ring around the hospital, ring the radiology department, ring the ECG department. And so what makes a good F1, I think, is being really, really organized, being proactive. I found that it took me a long time to be good because I kind of didn't know what I was doing very well at the beginning. I just wasn't a great member of the team because I was always asking for other people to tell me how to do things, or, you know, and there's a lot of bureaucracy, and there's a lot of kind of, if you want to get a thing done, you might have to ring someone 3 times, and then they tell you to ring this person. And there's something very simple like, getting a test done can take quite a long time, and you need to get those all done on time if you want to leave at 5 p.m. And for every test you do, it's your responsibility to chase the result. So all those tests, you're going to, this person needs a blood test, that person needs a blood test, everything you need to then go back and look at the result and then act on the result and document that you've looked at the result and what you're going to do about it. So that I mean, you can already see that's how your whole day is going to be taken up, basically. It's not I've got in the corner, you're probably not going to diagnose these diseases, decide treatments, read CT scans, do research, or any of that kind of crazy stuff. You're going to be doing these things that are kind of very mundane, but they are how the department works. And it's really, really important, because if you forget, you forget to do a test, to do a blood test, or you did a blood test, but in the mess you forgot to look at the result, and then the result comes back and it's really abnormal. That's a disaster. I've been in that situation several times where, there was, I should have chased something up and I didn't, because there's so many things to do and you're tired and you're not 100% sure about things. And then it turned out that it was a very abnormal thing. And I kind of didn't see, didn't know, didn't do anything about it. It's a bit of a disaster. I think, unfortunately, often you do learn by making mistakes, but just to give you a flavor of what the morning involves, ward round, and the evening is chasing all your jobs. At the end of the day, you give handover to the on-call team. So, I mean, I don't know whether I'm telling you stuff that's very obvious, but during the daytime, the hospital is staffed by individual teams. So there's a cardiology team, a respiratory team, a gastro team, each of which has an F1 and F2, a registrar, a consultant. And then after 5 p.m., everybody kind of goes home except one on-call team. And that team will consist of just one F1, F2 registrar looking after basically all the wards all together. So when each team goes home, they will give handover to the on-call team. So if you're the cardiology team and you're looking after, say, 10 or 12 patients up until 5 p.m., you're gonna basically hand over not all of your patients, but just a couple of your patients that you're worried about, that you think someone needs to keep an eye on. So maybe 2 or 3 patients that you want the evening team to know something about. And kind of any tests that you've done during the day where the result hasn't come back yet, you might hand over to the on-call team to know that. So your on-call team takes handover. So that's basically called continuity of care. That the patients are looked after 24 hours a day by different teams of doctors. It's basically 3 teams. It's your day team between kind of 8 and 5 p.m. an evening team between kind of 5 p.m. and kind of 11 or midnight, and then there's a kind of and then there's a kind of night team overnight kind of thing. So there's usually kind of 3 teams going on. And each of them need to hand over what, without forgetting anything, because this is what's important. Anything you want to add, Mahad, in terms of like how a short day works?
No, I think you covered it. Short day, you have most of the time, obviously depending on where you are and where you end up having a job as a junior doctor. You should have support, especially in the beginning as an F1. You should have your F2 or an SHO registrar. Obviously with each team, someone might be on leave, someone might be doing something different. There are times that you might be slightly less supported, but most of the time there's someone there with you. So your job, as I said, is receive handover is basically which patient has been assigned to your team. So somebody came, let's say you're a cardiology F1, somebody came in last night with an NSTEMI, okay? And they've been started on aspirin and clopidogrel and this and that. You're gonna go to the morning handover and they'll tell you this and this lady, 65 years old with diabetes, blah, blah, blah. And she is now on this ward and she should be under cardiology because that's what happened to her. So what you do is you go to your list and you'd write her name in and write which ward she's in and what things have been done for her so far. And then once you go and see her on the ward round with your team, you can tell the consultant what's been done and you'll see them together as a team, write an update and whether you're going to change her management and take it from there. Okay.
Sounds easy. Yeah, I don't think it's that easy, really.
It's not that easy, but it's always good to have it's always good to have a general idea of what. So that's so far that's you've taken handover.
Yeah.
You've updated your list. You've seen that patient with your consultant. Okay. You've written something. Can you hear me?
Yeah, I can hear you.
Yeah. You've written something down in the notes about what's going on. The consultant said, oh, she's had an NSTEMI. She might need an angiogram. Somebody needs to discuss, because we're a small hospital, somebody might need to discuss with a cardiologist sitting in, another part of the country with a bigger tertiary center, to call them and ask if she needs to have PCI, Okay, so that's what you write down on your jobs list is call cardiology in this and this hospital to discuss whether she can have PCI. So that's your job, okay? And she also had an acute kidney injury when she came in, so you have to check what her blood tests are now, okay? So that's another job. And then later on, you've spoken to cardiology. They said, oh, PCI, she's had an NSTEMI, not yet, so she might be listed next week.
Yeah.
And you've had a look at her user-knees and you see that they're not improving so much. So you need to hand over because you're worried about her to the on-call team after 5 and say, I don't know if we should give her fluids or not, but just keep an eye on her. Okay, yeah. So that's sort of an overview of what you could be doing, just with an example in there. Okay.
Times 10 or 12 or more.
Yeah, times whatever. Depending, and obviously, generally speaking, if the more patients you do have, you usually have a bigger team, generally speaking.
Yeah.
Okay. But
yeah, as you said, you're typically you're well staffed during the day. Let me move on to the long.
There's a few. Give me a second, sorry. There's a few questions in the chat that I was trying to answer a few questions while you were talking. So I'll go back to the first one because I feel like you might know a little bit more than me. A little bit different from the topic, but do you have an idea on how things change in terms of applications after Brexit for foreigners?
Yeah. Okay. Yeah.
I think if you can
Yeah.
have a
I mean,
quick answer for that, otherwise
yeah.
we
I'll
can save it
quickly
for
answer
later.
it. Although I kind of didn't want this talk to be about like how to apply and stuff, but
Mm.
I think what they've done with Brexit is they have um, got rid of the PLAB as a requirement for non-EU students who graduate in the EU, which is a massive thing. And I think so. I think the current non-EU citizens are really, really lucky. They've really lucked out this year, and that in that it sounds like they can pretty much apply just like the EU citizens to start as an F1. Um, and I think that's because of the current issues with the pandemic and Brexit that basically the UK wants to get a load of doctors in. So I think that is a huge thing in my year and had in your year. There were many of our friends who were non-EU citizens that had a really difficult time, and they had very limited options. And
Yeah,
whereas we basically graduated in July and started working in August. So whereas everyone else took 1 year, 2 years, more than that, and many of them have kind of either started specialty recently or they still haven't had the opportunity to do that. So I really feel for them. So I definitely think the non-EU citizens should you know should
give it
really
a go.
think hard. Yeah, should really think hard about giving it a go. And a couple of people have asked me about America, and even those guys. I mean, we all have our dreams, so I can't sit here and say that that is impossible, or But I think it's a huge. People have to really research what they want to do, and also I do think applying to the UK is the only opportunity where you're going to start working like straight after you graduate, and also be able to work at a level that's kind of suitable to how you've graduated, because to be frank, the Italian graduates are really lacking in their clinical skills, and I think the F1 is a kind of very safe place where you can actually turn up and not really know what you're doing and learn. Whereas I think I can't see that being that okay in other places. Because in America you don't have an F1 year. You start directly as a resident as in specialty. I just think it's a much more realistic step. So basically
I think
the
it's
difference between
probably because they have their not residency, their internship year within their courses in like America or some other places. So they would expect you once you've graduated to have those clinical skills under your belt. Whereas in the UK, they don't.
Yeah. So I think there's kind of two issues.
And quickly, Sai, what about, so you answered for non-EU, okay, that graduated in the EU.
Yeah.
What about EU graduates, sort of that, like an Italian citizen?
So basically,
someone from Germany, someone from.
So basically, the government has added like medicine to the list of like shortage jobs. So as far as I'm aware, EU citizens, non-EU citizens can all apply.
Okay.
And so, so I don't know whether that means a lot more people are going to apply this year or next year, but that's a slightly different question. But yeah, I think everyone has an opportunity to apply now, and I think they should, is basically the point of this talk. I think the people who graduated in Italy, they should all really try and apply and work as F1s, because I just think it's the best thing for people graduated from Italy, because it's just you can see that it's something realistic, and you're gonna actually practice as a doctor, and you're actually going to learn. The main difference between kind of Britain and America is America has an entry to basic training exam. So you have to do the USMLE before you start basic training, which means after 6 years of studying on a book, you have to probably set aside another year minimum to study the USMLE. So I kind of, when have you done any clinical skills or seen any patients? So I think that's really difficult, a really difficult path to go down. Whereas the UK has an exit from basic training exams. So we start with kind of, as you can see, just being like the vegetable peeler or the dishwasher in the restaurant and working your way up in a kind of realistic way. So I didn't do any exams as an F1 or F2. I had a complete break from studying. I would say, frankly, I didn't study at all. I was just doing my job. And I've got a slide about how you learn, but you basically learn by just absorbing what you're seeing and just kind of doing your job, basically. And then is only now kind of, as in my first year of specialty, that I'm doing some exams. So I think if you were designing good medical training, like if you or I were going to start a medical school, it should balance kind of theoretical knowledge and competence. Competence, I think, is a word I didn't hear very much when I was at med school. I'm extraordinarily grateful for my time in Italy, because I wouldn't be a doctor without it. But I do want to like give back to my university in the sense that I think that you need to balance both things. You need to talk about competence. If you're going to train someone to do a job, it can't just be learning theory about diseases, because anyone could like read that in a book. You actually need to be kind of able to do a few things. Anyway, so is that answering that question?
Definitely.
I can see.
Yeah, I think that answered that question. Definitely. I'm just going to try and whiz through the other questions, because I think that was probably the one that I wanted you to answer quickly. Let's have a look. How long are your long days?
Okay.
So long days.
Let me go. I've got the next slide about long days. So let's.
Do we have that on the slides? Okay.
Yeah, let me talk about long days, and then we'll keep getting questions, and then maybe at the end we can do more questions.
Should we do the questions at the end then?
Yeah, we can kind of do them like this as well, if they're relevant. So we've talked about short day, where you're well supported. It's just always ward round in the morning, and it's jobs in the evening. And hopefully, like you have your patients for a couple of days. So hopefully you get to see what happens to them. You know, whether they get better or get worse or go home. So that's kind of how you're learning, by looking after your patients day to day. So on your long day. So that's called being on call. Typically, that's so when you finish you kind of do your normal day between 8 and 5, say, and then at 5 o'clock, all the other F1s go home, but you stay back. So say, so everyone has to go home, but one person basically stays back. So you might do that kind of Monday to Thursday. Someone else will do it from Friday to Sunday, and then so it will be your turn in the rota every once in a while to do evening on calls, and then similarly on nights and on weekends you're doing a similar kind of on call work. So basically the on call team is like an emergency team. They are there to look after the patients out of hours and keep them well, basically. Whereas the day team is the ones that are doing the ward round every day, making the plans, getting things done. Whereas you're just there for the sickies, basically. So you usually end up doing one of two things, either looking after the wards, or clocking in new patients. So obviously during the night and in the evening, there's going to be new patients coming into the hospital who have been taken ill. So some people will be basically seeing those new patients, examining them, taking their history, admitting them into the hospital. And then some other people will be looking after all the patients who are there on the wards. Most of those patients are going to be completely fine overnight. They're not going to do anything. The nurses are going to look after them. You won't need to see them. But some of them are obviously going to be unwell, and you'll be called for any of them. So the bleep. When I got my first bleep, I didn't know what a bleep was, and my F2 played what I now understand is a fairly funny joke, but didn't seem like a joke at the time. Was like, I was like, what is this thing? How does it work? And he literally gave me a bleep, and he was like, just you just see how it works out. I held it like this, and it started beeping, and I was like, what the hell? What do I do with this? And then essentially, so the F1 is the person where if any nurse has anything they're worried about their patients, they're in the F1. So you've got all these wards of patients. Say you have 5 wards of patients. They might be 70 patients, 100 patients. Out of hours, there's just nurses, and the nurses basically, give the patients food, look after their personal needs, and they'll do a set of observations like every 4 hours. So check their heart rate, check their temperature every 4 hours. So the nurses look after the patients. If they're not happy with anything, if they're worried about their patient, they will bleep the F1. So the F1 carries this bleep that, depending on how bad your night's going, it could like beep at you constantly, like constantly beep, 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 beep. And it will be anything and everything. Like I've got a couple of random examples on this slide, like, doctor, this man is bleeding from his bum. This 73-year-old lady has fallen over on the ward, or just something completely random, like this man's oxygen sats at 83. What do you want me to do? This man says he's got chest pain. What do you want me to do? So your job as an F1 is basically to deal with all those things. So it's like prioritizing, doing what you think is important, so this is when you're going to actually think for yourself and deal with all the issues. So you will slowly learn how to deal with each problem. So when you start off, you're not going to have a clue what to do about anything. And on your on-call team, you will have someone more senior than you, like an F2 or an SHO, and you will have a registrar who are also quite busy. But at the beginning, you will ask them about everything. And later on, you'll get better at working out what to do about things. So that is basically ward cover, which can be a bit of a nightmare. And that's usually what an F1 does. You're pretty lucky if you get to be, clerking in new patients, because that's kind of fun. And typically the registrar and more senior people will be doing that. They usually let the F1 basically look after the wards, and it's a bit of a nightmare. I've put on here the SBAR tool, which is a good starting point about how to talk about patients. And nurses will use this a lot, because you can see some of the examples I've written. If someone says, "Doctor, this man is bleeding from his bum," well, what do you want me to do about that? Like over the phone, right? There's someone on the other side of the hospital. Unless someone gives you a proper handover of how you're talking about patients, what am I supposed to do about that? So the SBAR the SBAR tool of talking about stuff is S situation, B background, A assessment, and R recommendations. So it's kind of saying something like, so the situation is, I've got this man who has started bleeding PR profusely. Okay. The background is that he's 83 years old. He's known colorectal cancer. He came in 3 days ago to hospital with abdominal pain. So that's his background. The kind of assessment is, if it's the nurse talking, he looks pretty unwell. He's got a high heart rate, I think, and his blood pressure is low. So I'd really like you to come and see this gentleman straight away. Our recommendations is, could you please come, doctor, could you please come and assess this patient? So then you kind of know that if you've got 10 bleeps, that sounds like the thing you need to go and sort out. Whereas if someone says, doctor, I've got this lady who's like a little bit in pain, but she actually looks fine. Her obs are normal. I'm not that worried about her. She just needs a paracetamol. When you've got time, do you mind coming in? Remember, you're the only person that can prescribe drugs. The nurses can't do that. So if the nurse needs anything, like someone's got a headache in the middle of the night, they have to call you. If there's anything, that's an annoying thing to have to do in the middle of the night, but you have to actually go and prescribe that medication. So the SBAR is a kind of way of talking about, it's often used by nurses, and it's a very helpful way to talk about patients. yeah, as I said, this is when you're going to feel more like a doctor. This is when you're really going to learn, and you're going to have a lot of very interesting experiences. Like I can remember, like a 35-year-old man who, the nurse rang me in the middle of the night and said, "Doctor, this young guy has just vomited a huge amount of blood, like onto the floor of the ward." And I went up there, and that man looked like this close to death. Like he looked grey as hell. And there was a crash call. Everyone came, and then I ran like crazy for like O negative blood and all that kind of stuff. So sometimes you end up kind of this is the time when you will be like you're there for the emergencies. So in terms of crash calls, I've got like 3 pictures of bleeps there and 1 pictures of someone doing CPR. So it does happen. I mean, if someone has a cardiac arrest in the evening or middle of the night, you are the person that's going to go and deal with that. Or if someone gets very sick, or whatever kind of acute stuff like frankly septic or has a seizure or whatever it is, anything could happen really. I mean, people fall over and bang their head and then there's blood everywhere. Whatever. That's what you're there for. And you're going to turn up and you're going to take an ABCD approach. And in a crash course situation, you either get your regular bleep where someone bleeps you and then they just ask you something, and then you have a crash call where you kind of run straight away. And in that, and if you went to a crash call, then your registrar and everyone else will turn up as well. You won't be on your own. So, Matt, do you have anything to like say about kind of crash calls and that kind of stuff? I mean, they happen. They don't happen every night, hopefully, kind of thing, right?
Crash calls, definitely. So crash calls. I mean, most crash calls are, generally speaking, most of them that I've been in have not been cardiac arrests, fortunately. And I think it's something that you dread starting as a junior doctor. What am I going to do in this situation? It's going to be so acute. Do I remember all of the A, B, C, D, E's? And that goes out of the window. But I think it's just fairly sort of try and the thing is, once you get there, you're not going to be a team leader of a crash call unless obviously you do really well, and later on in the next few months, once you're training, you can do that and you take that responsibility on yourself. You're never expected to lead a crash call on your,
No,
generally speaking,
you're not going to be expected, the expectations are going to be very low from most F1s at the beginning. Let's be like frank about that.
Of course.
Everyone, in a hospital, you have new F1 starting every year. So everybody is used to these people turning up once a year, not knowing anything. So that is fine. You're not going to know how to use the phone, how to use a bleep, how to get into the hospital, where the canteen is. You're not going to know anything. So that is fine. I think that's the kind of important thing to say in terms of like starting out, right?
Yeah, definitely. And once you go to that sort of crash call, generally speaking.
Bro, I can't hear you, Matt. I don't know if you've muted yourself. Can the rest of you guys hear me? I can't hear me.
Yeah, we can hear you, not Mahad.
Okay, well, we'll wait for Mahad to turn up again. So yes, I think that's kind of what I want to say about on-calls. They are the most interesting part of your day, the most tiring part of your week, like genuinely exhausting. Like if you imagine this, you have like a bad on-call, and you just have to deal with so many things. You go home, you literally like knock out, fall asleep. You have to wake up the next day and go back into work, and you do that for 4 days. It is, it can be, that is the most tiring part of your job. But it's when you get to actually do stuff. So I have so many just interesting experiences, and yeah, ward round and things are much more boring, really. So I've got a slide here about how do you summarize a patient? Let me just get my. So, like, if you're gonna go and see a patient, right? So someone asks you to go and see a patient, you know nothing about them, you know. So some nurse is gonna be like, oh, you know, this man has chest pain or whatever. What? And you don't have that much time because someone has asked you to do something else. Okay, so you're gonna go there. You've never met the patient before. They're not you. Your team hasn't looked after them because this is out of hours. So you're looking after like all these 100 patients. So, you know, someone's fallen over and banged their head. Okay, how are you going to go there and like in your mind try and understand who this patient is? Okay, because if you don't have like a really strong grasp, they're all going to sound the same to you, and you can't be like, oh, this old man fell over. You have to kind of know what is going on with that patient. You know, are they an old, if they're an old man that fell over, is different from an old man who's on warfarin that fell over, or an old man that had previously had a chronic subarachnoid hemorrhage and fell over, or an old man, you know. So you've got to know that you've got to get the important details. I mean, you'll learn what the important details are that you need to find out, but how are you going to summarize a patient in your mind? So the kind of things you have to look at and that you need to make sure you've looked at are the patient's clinical notes. So as I said, everything is always written down. So if you're going to see a patient and they've been in hospital 3 days, everything's going to be written down about what's happened to that patient. So all of those patients' clinical notes, their past medical history, what medications they're on, why they came into hospital, what treatment they're on, what the consultant thought that morning, all of that, you need to skim read all of that. Their most recent like kind of blood results and investigations. So when you open up the computer, you can see like, you know, this morning they had a chest x-ray or they had some blood results. You will learn how to interpret the common blood results. I mean, okay, there's a bit of an, you know, you've all gone to med school for 6 years, so you will kind of know how to interpret a full blood count, a U's and E's, that kind of thing, and you'll quickly learn like what's important to look out for and what things mean. So looking through their results, the observation chart. So I don't know if you guys have seen a news chart, but a news chart is what does it stand for? Something early warning chart, I think. I don't know. Early warning chart or something. Anyway, it's called a news chart, and it records basically the patient's respiration rate, heart rate, oxygen sats, blood pressure, and temperature. And it kind of has your kind of white area, which is like your normal values for those, and then it has a red area which is clearly abnormal. So if a patient has a recording in an abnormal area, they get a point for that. So you know, your absolutely normal, like fine person is going to have a news score of 0, and then if you know their blood pressure is low and they're tachycardic and they've got a temperature, which means they're septic, then their news score will be really high, and then the nurse will ring you and say, "Doctor, I've just done these observations. His news." So it's a trigger system essentially. It's a trigger system for the patients who are in hospital. They get obs regularly, and then if their obs are not right, it triggers things. And the idea is that you pick up on abnormal physiology. Going back to your physiology, you're picking up on something is not right about this person, you know. And as Mahad said, most crash calls are not cardiac arrests, and that's how it should be. So in the past, they had a system where if someone has a cardiac arrest, like their heart stops, then you put out a crash call. But then people realized we should be going to see that patient before their heart stops. So a crash call is supposed to be a peri-arrest call, not an arrest call. So you're supposed, you know, that's call supposed to go out for urgent help, you know, in that period before they arrest, to stop them arresting. So when they are seriously unwell, but before they actually arrest. So that you've got that your observation, your system of doing observations that the nurses are doing, and your news chart is really important. Then you have their drugs chart, obviously. So that's everyone will have a chart that has what medication they're on, and so that's important to have a look at, and then examining your patient. So those is kind of all the things that you have to have a very quick glance at when you're for you to kind of see a patient. So anytime you're answering